Welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is applied anatomy of the neck. Applied anatomy of the neck. This is part 2 of the lecture. Check out the other video on applied anatomy of the neck, part 1. So let me talk about lymphatics in the neck. Lymphatics in neck. Most superficial tissues of the neck are drained by lymphatic vessels that enter the superficial cervical lymph nodes. These superficial cervical lymph nodes are located along the course of the external jugular vein. Always remember that lymph from these lymph nodes drain into inferior deep cervical lymph nodes. Then most lymph from 6 to 8 nodes that drain into the supraclavicular lymph nodes accompany the transverse cervical artery. The main group of deep cervical lymph nodes actually form a chain along the internal jugular vein, mostly under cover of the sternocleidomastoid muscle. There are other deep cervical lymph nodes. The other deep cervical lymph nodes include the prelaryngeal, pretracheal, paratracheal, and retropharyngeal nodes. Efferent lymphatic vessels from the deep cervical nodes join to form the jugular lymphatic trunks. The jugular lymphatic trunks usually join the thoracic duct on the left side. What about the right side? On the right side, the vessels enter the junction of the internal jugular and subclavian veins. That junction is actually called the right venous arc. The right venous arc. So on the right side, the vessels enter the junction of the internal jugular and subclavian vein, the right venous angle. They enter the right venous angle directly or via a short right lymphatic duct. Right here is an illustration of the cervical lymph nodes, the lymphatics that drain the neck region and the lymph nodes that are concerned are all illustrated there. The deep cervical lymph nodes are clearly shown there. Tonsillectomy is a procedure I need to talk about now. Tonsillectomy is removal of the tonsils. It is performed by dissecting the palatine tonsils from the tonsillar sinus, that's the tonsillar bed. You could do it by a gonotine or snare operation. Whatever procedure you do, you need to remove the tonsil and the facial sheet covering the tonsillar sinus. Note that there is rich blood supply of the tonsil, so bleeding commonly arises from the large external palatine vein, or at times you have bleeding from the tonsillar artery or from some other small arteries. In the course of tonsillectomy, the glossopharyngeal nerve accompanies the tonsillar artery in the course of tonsillectomy. You need to note and be mindful of the glossopharyngeal nerve, because the glossopharyngeal nerve accompanies the tonsillar artery on the lateral wall of the pharynx and is therefore vulnerable to injury because this wall is thin. The lateral wall of the pharynx is thin. So the glossopharyngeal nerve is vulnerable to injury in the course of tonsillectomy. Right here is an illustration of the tonsils. What about adenoiditis? Adenoiditis is actually inflammation of the pharyngeal tonsils, that's the adenoids. So the condition can obstruct the passage of air from the nasal cavities through the cornea into the nasopharynx, and then the individual is therefore forced to be involved in mouth breathing. Infection from enlarged pharyngeal tonsils may also spread to the tubal tonsils, and this causes swelling and closure of the pharyngo-tympanic tubes. What about foreign bodies in the laryngopharynx? Foreign bodies entering the pharynx may become lodged in the piriform fossa. If such foreign objects like a chicken bone is sharp, Such object may pierce the mucous membrane and injure the internal laryngeal nerve. The superior laryngeal nerve and the internal laryngeal branch are also vulnerable to injury if the instrument that is used to remove the foreign body accidentally pierces the mucous membrane. So you need to be careful when you're removing the foreign body from the laryngopharynx. Right here is an illustration of the laryngopharynx and other parts of the pharynx, the oropharynx and the nasopharynx. They are all shown there. Now let me talk about radical neck dissections. Radical neck dissections are performed when cancer invades the lymphatics. In the course of radical neck dissections, the deep cervical lymph nodes and the tissues around them are removed as completely as possible. So you must know that the major arteries, the brachial plexus, the 10th cranial nerve, and the 10th cranial nerve is vagus nerve, and the phrenic nerve are all preserved in the course of radical neck dissection. So when you're doing radical neck dissection, you preserve the major arteries, the brachial plexus, the 10th cranial nerve, and the phrenic nerve. Most cutaneous branches of cervical plexus are removed in the course of radical neck dissections. Why do you have to do radical neck dissection? You do it to remove all tissues that contain lymph nodes in one piece. So in case of cancer, the deep cervical lymph nodes, especially the ones that are located along the transverse cervical artery, may be involved in the spread of cancer from the thorax and abdomen. That's why we say they are cervical sentinel lymph nodes. So once you see them enlarged like that, there might be indication that there is cancer spreading from a primary tumor elsewhere that is spreading, metastasizing, spreading to the neck. So because of the enlargement of these deep cervical lymph nodes, the enlargement may give the first clue that there is cancer in the thoracic and the abdominal region. The deep cervical lymph nodes are called the cervical sentinel lymph nodes. Now let me talk about medical imaging of the neck. Medical imaging of the neck. Radiography is very important. Radiographic examination of the cervical vertebral column involves anteroposterior radiographs, lateral radiographs, and then oblique radiographs as well. When you look at the lateral view, it's very important when you're considering neck injuries for you to understand what actually is wrong. When a fracture is suspected, the lateral view is examined before the person is moved to other projections, because it actually gives very good clue to when there's fracture. You can easily appreciate it from the lateral view. Right here is a radiograph of the neck, the anterior posterior view, and then the lateral view. There is a fracture indicated by the region of the arrow. There's a fracture there in the region of the arrow. When you look at the region of the arrow carefully, you will see that there is a fracture there. Myelography is another procedure I need to mention as far as medical imaging of the neck is concerned. Myelography is a procedure in which you have radiographic contrast object that is given so that one can visualize the spinal cord and spinal nerve roots. Myelography, you see the extent of the subarachnoid space and its extensions around the spinal nerve roots within the dural root sheaths. But presently, high resolution magnetic resonance imaging has supplanted myelography. People prefer that to myelography now. Right here is an illustration of myelography, a myelogram of the neck, so you can appreciate the spinal cord, the spinal nerve roots, because of the contrast substance that was given. Then computed tomography, the CT of the neck is something I really need to talk about. Computed tomography enables one to differentiate between the white and gray matter of the brain and spinal cord. In this case, we're actually looking at the spinal cord in the region of the neck. Computed tomography has improved the radiological assessment of fractures of the vertebral column, especially around the neck as well, in this case. So it helps in determining the degree of compression of the spinal cord. Computed tomography produces images of the vertebral column that are used to detect fractures, other lesions, and congenital anomalies. The dense vertebrae attenuate much of the X-ray beam, and then when you look at the CT scan, it appears white. You see structures appearing white, so with a whitish color. Right here, CT scans, computed tomographic scans of region of the neck. You can see the sagittal view there, a sagittal section. Then you also have the axial sections shown there as well. Now, magnetic resonance imaging of the neck, very important. So magnetic resonance imaging, like the CT, is computer assisted imaging procedure, but X-rays are not used, unlike what you see with CT. Magnetic resonance imaging produces extremely good images of the vertebral column around the neck. So you can see the vertebral column, the spinal cord, and you can also appreciate the cerebrospinal fluid in the subarachnoid space. Magnetic resonance imaging clearly demonstrates the components of the intervertebral disc, and it shows their relationships to the vertebral bodies and the longitudinal ligaments. Herniations of the nucleus pulposus and its relationship to the spinal nerve roots are all clearly defined when you do MRI, when you take an MRI image of the neck. Magnetic resonance imaging is the imaging procedure of choice when you considering you want to study intervertebral disc disorders, and is gradually replacing myelography and CT for the study of such disorders. Okay, let me talk about fracture of the dens. The transverse ligament of the atlas is stronger than the dens of the axis, that's the second cervical vertebra. So fractures of the dens make up about 40% of axis fractures. So before the axis will be fractured, you find out that the dens is also already fractured. The most common dens fractures occur at its base, that is at the junction with the body of the axis. Such fractures are unstable. They do not unite easily because of the transverse ligament of the atlas, which becomes interposed in such a condition between the fragments, and because the separated fragments of the dens are no longer have blood supply. That's the segment that is fractured and separated lacks blood supply in such a case, so you have a vascular necrosis, so which is what we don't want at all. Almost as common as fractures of the vertebral body inferior to the base of the dens. Fractures of the vertebral body inferior to the base of the dens are very common, and this type of fracture heals more readily because the fragments retain their blood supply. So other dense fracture results from abnormal ossification patterns. So the dense fracture could occur at different sites as shown in the illustration there. It could be at the base, it could occur towards the apex of the dens. What about rupture of the transverse ligament of the atlas? So when the transverse ligament of the atlas ruptured, the dens is set free, and this results in atlantoaxial subluxation, which is actually incomplete dislocation of the median atlantoaxial joint. You could also have pathological softening of the transverse and adjacent ligaments, and this results from disorders of connective tissue. So this may also cause atlantoaxial subluxations. Like you see in 20% of people with Down syndrome, they have laxity or agenesis of the transverse ligament of the atlas. Dislocation owing to transverse ligament rupture or agenesis is most likely to cause spinal cord compression. So this is more common than a case of fracture. A case of fracture of the dens is less likely to cause spinal cord compression. So we are more worried when there is rupture of the transverse ligament of the atlas, because it could cause compression of the spinal cord. In fractures of the dens fragment is held in place against the anterior arc of the atlas by the transverse ligaments, and the dens and atlas move as a unit, so it's less likely to cause a spinal cord compression. When there is absence of a competent ligament, that's the transverse ligament, the upper cervical region of the spinal cord may be compressed between the approximated posterior arc of the atlas and the dens, and this causes paralysis of the four limbs, both the upper limb and lower limbs, and this is called quadriplegia. The spinal cord may also be compressed towards the medulla of the brainstem, and you could have death occurring. Approximately 1/3 of the atlas ring is occupied by the dens, 1/3 is occupied by the spinal cord, and the remaining 1/3 by the fluid-filled space and tissue surrounding the spinal cord. So you have what we call the Stell rule of thirds. So some people with the anterior displacement of the atlas may be relatively asymptomatic, they don't feel anything until a large degree of movement greater than 1/3 of the diameter of the atlas occurs. So when they are still, there is no issue, but once they exhibit some kind of movement greater than 1/3 the diameter of the atlas, they now have problems. Sometimes inflammation in the craniovertebral area may produce softening of the transverse ligaments or other ligaments of the craniovertebral joints, and this can cause dislocation of the atlantoaxial joints. Sudden movement of a patient from a bed to a chair, for example, may produce posterior displacement of the dens and injury to the spinal cord in case where you have issue with the transverse ligament of the atlas. Right here is an illustration of a superior view of the atlas and axis, and the ligaments, the transverse ligament of the atlas is shown there. Don't forget to subscribe to this channel. Thank you so much for listening. Goodbye for now.